I gave this lecture on Monday in class and realized that everyone got a lot out of it. We don't need to make this super hard this week. There's just some basics about effusions that you should know if somebody hands you a syringe from a situation such as this. Effusion is usually defined as an accumulation of fluid. And it can be an accumulation of normal fluid or it can be an accumulation of abnormal fluid. And one of the fluid analyses that you guys have been doing all along and you're familiar with is urine. So we'll use the beginning of doing urine to help us with effusion cytology. So the first thing is collection. We're probably going to be talking a lot about abdominal and thoracic collection of abnormal fluids, although they can occur anywhere in joints, even CSF fluid and transtracheal washes can still use all the same prep procedures that we're going to do for the effusions that we're going to talk about here. As far as collection goes, the terminology this week that you should recall from your early terminology days would be the term for collection from the thorax, which is thoracentesis, from the abdomen, which is abdominocentesis or paracentesis. I believe that the quiz even has collection from the pericardial sac around the heart, so you can figure that one out. And you guys all know the cystocentesis for bladder collection. Collection is the first thing we'll talk about. And if somebody hands you this syringe of thoracentesis effusion, what are you going to do with it? The first thing you're going to do is just like urine, you're going to evaluate it grossly for color, turbidity, possibly odor, and treat it that way. One other thing that I did mention in class is that we're usually responsible for, if the veterinarian is pulling a large quantity of fluid from the abdomen or thorax, you guys are responsible for keeping track of how much is pulled off that chest or that abdomen. So if somebody's pulling 200 or 300 mLs of fluid off, you don't want to lose track of that. So remember, you're responsible for volume. One of the most important classifications for these fluids is total protein. We probably won't be dealing with specific gravity too much unless the total protein falls below 2 grams per deciliter. So for the most part, we'll be getting a total protein on these fluids. That will help us classify it as to being a transudate or an exudate. The other thing that's important in classification is it very cellular? Well, we can assume that most fluid that isn't clear is going to have a lot of cells in it. This is a chylothorax, and this may be one of the exceptions to that, but let's not go with that. Let's talk about total protein and cellularity, often referred to as the total nucleated cell count, which you are going to do a little bit more of in lab. There is a table in your lab class, and there's also one in the Seurat text on page 387. You can see here that we have transudates, exudates. The modified transudate would be explained to be more like a thinner fluid but has a bit more cellularity. But let's stick with transudates and exudates first. Transudates can often be an effusion that's caused by a hypoproteinemia or a right-sided or left-sided heart failure. So it's usually a thin, clear fluid that is there by way of having lower protein levels and things like that. Exudates would be more like a perforated intestine, infection, and necrotic. Necrosis maybe in the abdomen on a tumor that's causing a thicker fluid with a lot of cells in it. As far as color goes, again, it would be more clear colorless or pink tinged for the transudates, and exudates can be pretty much any color. The big deal here is if the effusion is less than 3 grams per deciliter of protein, it's going to usually fall in the transudate or into the modified transudate category. If it's greater than 3, will usually fall in the exudate. Total nucleated cell count. This I know is giving you numbers, but a lot of times you're just going to look at it and you're going to say, wow, there's a lot of cells here, or there's really not very many cells. We'll talk about cell types later. Once you've done the gross analysis of the fluid and possibly even done, put some in a culture and some in an EDTA tube or possibly a clear red top tube without separator serum, then you want to make a slide. And you don't want to spin it down even if it's very thin. You want to look at an unspun sample first and then determine if it's a cellular sample or not. So you're going to make a prep of this, and usually a line prep or even a squash smear may be good preps to use when trying to get some of that fluid onto a slide so you can view it. Also remember that when we're talking about total proteins down in the 3s and the 2s, it's not going to stick on the slide like blood, which has a 6 or 7. So once you take your sample and you get it nicely air dried, do not use a hair dryer, or if you do, keep it very far away from the heat till it's thoroughly dry. Then you're going to stain it very, very gently so that that will stick onto the slide. And usually if it's a thin prep, you're going to stain it more like blood. If it's a thick exudate, probably going to stain it a lot longer. So once you've got it stained and you look at it on the microscope, you do want to first look around on low power. I can't stress this enough. If you go up to high power, you're going to miss stuff, or the veterinarian's not going to be able to see what they want to see on the whole slide. So make sure that you leave it on oil. One of you guys already mentioned my doc doesn't want us to go to oil without him looking first, and boy, that's how I've been raised in a clinic too. So be careful about going to oil if you've got something interesting on there. They want to look at it before you do. So you guys really do know how to identify cells on this cytology. Some of them can look look very different because they're in fluid that is not in a happy place. So some of the, the biggest deal what we want this week is for you to be able to tell the difference between an inflammatory effusion and an effusion that may be coming from a neoplasia. So what are the cells of inflammation? It's really important that you know this, and you already do. The first line of defense, remember, neutrophils. So neutrophils, monocytes, eosinophils, sometimes mast cells or basophils, and sometimes a few lymphocytes. These are the cells of inflammation. And I won't get into this too quickly, but our monocytes, once they leave the peripheral blood, become cleanup machines out in the body, and they turn into really effective cleanup machines, and we call them macrophages. You can see that these guys look a lot like monocytes, but they're pretty revved up to do what they're going to do. If this was my cytology from my unspun effusion, I probably would not spin down the rest of the fluid and make a sediment because it's pretty cellular. And remember, guys, we don't care about red blood cells now that we're into cytology. We care about nucleated cells. So if you have a whole picture here of red blood cells with one lymphocyte, that is not a cellular sample. This, however, is a pretty cellular sample. Had it not been cellular, we would proceed then, just like with urine, to spin down some sample and get a sediment, and then do that sediment cytology instead. If you're submitting that to the lab, make sure the lab knows it's either an unspun sediment cytology, or a sediment cytology. Okay, your effusion is on the microscope. The doctor wants to know if this is inflammatory in nature, or is it looking more like a neoplasia? So I want you to look here and tell me how many neutrophils there are. Okay, good. There's about 4 neutrophils in this picture, right? So here they are, 1, 2, 3, 4 neutrophils. How many macrophages in this picture? There's 2, okay? And then what are these guys right here? I know this picture is small, sorry about that. These are red blood cells, and the normal mature lymphocyte is not a lot bigger than a red blood cell. So I'm going to call these normal lymphocytes. And there, we did it in class. So there's about 18 or 20 of them. So the question that you do need to ask then when you do report this out is, what is the predominant cell type in this cytology? Clearly, it's lymphocytes. So how I would report this one out is predominant cell type is lymphocytes. A few neutrophils and macrophages are noted. No bacteria seen. That's how I would note this. I hope that makes sense to you. By the way, this fluid is from a chylous effusion in a cat. The picture on our front page this week is a butterfly catheter gathering an effusion from a chest on a cat. Chylous effusion is going to be one of the cases you do in lab this week, and we do see it occasionally, more often in cats than dogs. I've seen it in a few Shelties, but it's a white milky fluid. Nothing looks like it, and it's basically the leaking of a thoracic duct. More on that later, not in my lecture. Okay, another area that we have to go to, especially when dealing in effusions, are, when we talk about inflammation, is the inflammation septic or not? And most often when we have an effusion that's septic, it means that there is a bacteria present. We do need to see that it is intracellular as well as extracellular. This is intracellular bacteria. And the neutrophils become pretty unhappy at this point. Remember how crisp those last neutrophils were in that picture? They were nice. There was no bacteria there. They look a lot like the neutrophils you see in blood. But these neutrophils look like they're very moth-eaten and fuzzy, and they're starting to, we've got all these vacuoles, and it's just very fuzzy looking. These are all neutrophils, by the way, all of them, every single one. And these are degenerative neutrophils. They're unhappy. We've got a septic situation. This is actually joint fluid from a horse that had a septic hock. So what is our predominant cell type for this horse's hock? Okay, degenerative neutrophils. And what other things do we see here? We see intracellular bacteria and a possible lymphocyte here. And it looks like the fluid was pretty bloody. That's our report. If you would go to your Seurat book and open up pages 380 and 381, you're going to see a flow chart, also called an algorithm, that helps us classify effusions and solid tumors. The solid tumors on this are over on the left, so we're going to concentrate on the chart on the right-hand side. And our sample type is fluid, and then classify the fluid on gross appearance, total protein, TNCC, total nucleated cell count, and volume. And we've kind of already talked about that. And then once we've classified it as a transudate, modified transudate, or exudate, then we keep going farther down the chart to examine the sediment. Do we see intracellular bacteria? Do we have nuclear changes in our neutrophils, such as karyolysis and karyohexis? And then you keep going down here to non-septic, septic, degenerative, and non-degenerative. So it's really not that hard. Take your sample and work it down the chart. There's a little exercise to do that this week too. Okay, so make sure you look at that chart. The last thing I want to talk about is the thing that we mentioned right at the beginning. The veterinarian wants to know, is this an inflammatory effusion or is it looking more like neoplasia? The signs of neoplasia in effusions is the absence of inflammatory cells. And to be quite honest here, I don't really see any neutrophils or macrophages, right? Instead, there is a uniform population of what we call pleomorphic cells. They are of the same cell type. Look at their chromatin pattern in their nucleus. Look at the cytoplasm. Okay, they're all different in size and sometimes in nuclear cytoplasmic ratio, but they are the same cell type with different sizes. This would lean us more towards a neoplasia. It is not our job to call this, but clearly this is not an inflammatory lesion as much as it's leaning more towards neoplasia. I hope this was helpful. I think we should probably do it a little bit more online. Feedback is good. Anyway, I hope that works for you. and I'll see you on the boards. Oh, by the way, you guys did really good on that bone marrow board. I thought that was a really hard question. I was going to change it before class started, but you all did fine with it, so you did good. Thanks.